Myasthenia gravis is a condition caused by abnormal weakness of certain muscles. It gets worse during activity and improves during rest. Myasthenia gravis is caused by an error in the transmission of nerve impulses to muscles. It occurs when normal communication between the nerve and the muscle is interrupted at the neuromuscular juncture, the place where nerve cells connect with the muscle that they control. So in other words, MG, or myasthenia gravis, is characterized by a weakness and rapid fatigue of any muscles under your voluntary control. It's caused by a breakdown in the normal communication between the nerves and the muscles, and there's a strong connection between MG and thymoma, which is a tumor that's located on the thymus gland. The pathophysiology of myasthenia gravis is arguably the best understood autoimmune disease, and its studies has led to fundamental appreciation of mechanisms of neuromuscular transmission. MG is caused by antibodies against the acetylcholine receptors, or also known as AChR, which produce a compromise in the end plate potential, reducing the synaptic transmission. A muscle-specific kinase has been recently found to be an antigen target in MG. That will be better explained on my chart here in a few minutes that's behind me. The autoantibody production in the MG is a T-cell dependent process. In MG, there is an interesting differential involvement of the muscle groups, in particular the extraocular muscles. So MG is more common in women that's younger than 40 and men that are older than 60. Patients with MG present with painless specific muscle weakness, and it's not generalized fatigue. Myasthenia gravis is a weakness in the muscles and typically affects the extraocular bulbar and proximal limb muscles. Droopy eyelids or double vision is the most common symptom with the initial part of MG. This occurs in about 3/4 of the patients that experience it. These symptoms progress from mild to more severe over weeks to months. Difficulty in swallowing, slurred speech, nasal speech, difficulty chewing, and facial neck and extremity weakness occurs. On the other hand, symptoms may remain limited to extraocular and eyelid muscles for the years. Symptoms may worsen with exposure to extreme heat or emotional stress, infection, systematic illness, pregnancy, the menstrual cycle, or drugs that affect neuromuscular transmission may exacerbate myasthenia gravis. Depression may be seen from the progressive and disabling symptoms, but it's not a very common symptom. Diagnostics and testing. So they have the bedside test, which is an ice pack test. This is done by placing an ice pack on the eyelids. Patients with myasthenia gravis have weakness of the eyelid muscles, so this helps to relieve that ptosis, and it serves as an indication that MG may be present. Serologic testing. Serologic tests check for the presence of antibodies in the serum. Seropositive means that there is a presence of antibodies in the blood, and seronegative means that there is not a presence of antibodies. A neurologist usually orders a blood test designed to detect antibodies to the ACH receptors. Electrodiagnostic testing is the next step that's usually used to determine MG. In electrodiagnostic testing, the electrodes are used to measure the electrical signals in the muscle. This test delivers a small shock from the nerve in the arm, leg, or face, while the other electrodes record the response of the muscle. An MRI may be used to detect the presence of a tumor if the patient has been diagnosed with MG. They would check for a tumor in the thymus. Complications. The most serious complication of MG is myasthenia crisis. This is a condition of the extreme muscle weakness, particularly the diaphragm and the chest muscles that support breathing. Breathing may become shallow and ineffective. While MG itself cannot kill you, the combination of decreased breathing ability, pneumonia, and aspiration can lead to death. So treatment for MG includes medication treatment, IV therapy, and surgery. Medications include cholinesterase inhibitors. These are medications used to enhance communication between the nerves and the muscles. These medications are not a cure for MG, but they can improve the muscle contraction and the muscle strength in some people. Corticosteroids are used, such as prednisone, to inhibit the immune system, limiting the antibody production. Immunosuppressants would be used with the corticosteroids. Your doctor might also prescribe other medications that alter your immune system. IV therapy that's used, plasmapheresis. This is a filtering process, sort of like dialysis. It removes the antibodies that block transmission of the signals from the nerve endings of your muscle receptor sites. However, the effects usually only last a few weeks, and repeated procedures can lead to difficulty in accessing veins, so it's not a preferred treatment. Intravenous immunoglobulin. This therapy provides your body with normal antibodies. Monoclonal antibody, used in some cases. It's normally only used when the other treatments have not been effective. So surgery is used not for the MG itself, but if you have a tumor on your thymus called a thymoma, the doctors will surgically remove the thymus gland. That's called a thymectomy. So some nursing interventions for someone suffering with MG or Myasthenia Gravis includes closely monitoring the respiratory system. That's your biggest concern with MG. To do so, you want to monitor respiratory status and ability to cough and deep breathe adequately. You want to monitor for signs of respiratory failure such as hypoxia, skin pallor, labored breathing, chest pain, and gasping for air. You want to maintain suctioning emergency equipment bedside in case there is a Myasthenia crisis. Monitor the patient's vital signs. Monitor for speech and swallowing abilities to prevent aspiration. If there are disabilities with speech or possible aspiration concerns, you would want to consult with a dietitian and a speech therapist to decrease the risk. Encourage the client to sit up when eating. Assess muscle status and determine level of functioning. Instruct the client to conserve strength and energy when they are feeling exacerbated. You want to plan short activities that coincide with the times of maximal muscle strength, such as early in the morning when your body has been at rest. You want to monitor for Myasthenia and cholinergic crisis warning signs, as we mentioned before. Administer anticholinergic medications as prescribed. Instruct the client to avoid stress, infection, fatigue, and over-the-counter medications, as some medications can cause the conditions to worsen. Instruct the client to wear a med-alert bracelet for in case of an emergency. You want to educate patients with MG to recognize and immediately report impending respiratory crisis. Current infections may worsen the symptoms of MG temporarily. Mild exacerbation of weakness is possible in hot weather. The risk of congenital deformality is an increased risk for offspring of women with severe MG. So neonates born to women with MG must be monitored for respiratory failure 1 to 2 weeks after birth. Certain immunosuppressant drugs have a teratogenic potential. So discuss these aspects with women in reproductive years before beginning the therapy of these drugs. And certain medications such as antibiotics, some beta blockers, and some antidepressants may exacerbate symptoms of MG. Those of which taking those medications will need to be closely monitored. Patients should always consult a neurologist before starting any new medication when they're on a therapy. So the chart behind me, this is explaining the disease process of Myasthenia Gravis. So here you have the motor nerve, and it is at the neuromuscular joint. It's going to connect with your muscle. So in between the joint and the nerve, you have the synapse, and along the bed of the muscle, you have the postsynaptic membrane. So this is where your receptors are located on the muscle. So when you look down here, your nerve axons are constantly releasing the acetylcholine receptor antibodies. So when you have Myasthenia Gravis, it's going to increase the production of your ACRH antibodies. And when that's being reproduced, it is going to block your synapses from receiving that message to contract the muscle. So normal muscle contraction occurs when acetylcholine is released from axons of a motor nerve. The ACHR binds to synapse receptors of the muscle, causing contraction. In MG, too much ACHR is being produced, and that's the antibodies. So in MG, too much antibodies being produced is causing the ACHR to block the muscle receptors, which inhibits the muscle contraction. So that is why this disease, when you are more active, you're going to have decreased muscle ability, because more exercise is going to equal more synapse blockage, which is going to equal your muscle use decrease the ability.